Assalamu alaikum and welcome to another video of Learn with Laraib. Today we will be discussing the remaining part of our CVS that will be heart histology, anatomy, and some of the electrical activity, venous drainage. It's just a mixture of everything and it will conclude this topic for us, which is relevant to physiology and anatomy only. Pathology and pharma will be done later. So starting with the structure of heart. So heart is a muscular organ which acts as a syncytium. That means that it acts as a one unit. Now, at a histological or cellular level, it does so because of the presence of gap junctions in the cells. This is an MCQ and an important one. Now, coming to the layers of the heart. So we have the pericardium and pericardium is further divided into fibrous and serous layer. The serous one has a parietal and a the parietal and a visceral pericardium. The visceral pericardium is also known as epicardium. So I have to explain this in detail so that we can easily know the placement of the pacemakers or where SA node, AV node are present. Then we have the myocardium, which is the main muscular layer and is responsible for the contractility. And we have the endocardium, which is an endothelial layer associated with the lining of the chambers and the valves. So if we see the SA node is present in the subepicardium, that means just below the epicardium, SA node is present. The AV node is present in the endocardium and the conduction pathway is present in the subendocardium, that means below the endocardium. So SA node will be in the subepicardium. Again, this is an important MCQ. Also, it lies in the upper portion of crista terminalis. So if there is a damage to these, if there is an MCQ which mentions a damage to crista terminalis or subepicardium, the damage will be to SA node. Similarly, AV node is present in the located in the postero-inferior part of atrial septum. So between the atria, the postero-inferior part, it is located, and if there is a damage to this, it will result in AV node damage. Again, this is an MCQ. Subconduction pathway, as I told you, is present in the subendocardium. Regarding the speed of conduction is highest with the Purkinje fibers, which conduct the action potential. Then the second one is atria, then ventricles, and then the AV node. So the speed of conduction is lowest at the AV node because you remember SA node to AV node through the Bachmann fibers. SA node, as we all know, is situated in the upper right atrium. Again, this is an MCQ. And we did about AV node. It's the slowest conducting system in the heart. So we have the right bundle branch and the left bundle branch. Again, we studied in the heart blocks the blockage of these bundle branches. So the right bundle branch conducting system here, it is present in the septomarginal trabeculae. This is again an MCQ in past papers, so that is why I am mentioning it. Septomarginal trabeculae. Okay, and again the first degree, second degree heart blocks, right bundle branch block, left bundle branch block, all of these we will do in detail in pathology, and we have already done a little before. So regarding Purkinje fiber, again, as I just mentioned, they have the highest conduction speed and they're the specialized heart muscles, which basically have a wide diameter. That is why the conduction increases in Purkinje fiber. Now we did in our action potential and ECG video as well that the SA node acts as a pacemaker due to increased firing, and that is because of phase 4 depolarization, which is basically the inward sodium current, and we did the action potential at S node in detail as well. S node is a pacemaker because it has the highest rate of discharge. All right. Now, if there is an abnormality, and let's say if the S node stops acting as a pacemaker, AV node will act as a pacemaker. If there is an abnormality in the conductive tissue, if there is a defective conductive tissue of heart, the moderator band is where the pacemaker will be placed, an artificial pacemaker will be placed in the moderator band. If there is a P to QRS dissociation seen on the ECG, that means that the SA node is not working properly. The pacemaker now placed will be in the right atrium. If there is a complete heart block, so completely heart block हो गया, इसका मतलब है SA node भी नहीं चल रहा, AV node भी नहीं चल रहा. So at least ventricles contract करें. The pacemaker will be placed in the ventricles, the right ventricle basically. So this was the whole structural anatomy and histology of the heart, and all of these are important MCQs. Now we will move on to the nerve supply of the heart. So the nerve supply of the pericardium is via the phrenic nerve, and it is also referred to the shoulders as well sometimes. Now the heart has the cardiac plexus. It has a superficial cardiac plexus and a deep cardiac plexus. The superficial cardiac plexus is present in the superior mediastinum, and I'll talk about this. First of all, just see that the sympathetic supply of heart, again an important MCQ, comes from T1 to T5. The parasympathetic, we all know, comes from the vagus nerve. So sympathetic will increase the firing at SA node, increase the heart rate, increase the contractility, and parasympathetic will do the opposite. It will actually prolongate the PR interval as well. So these preganglionic fibers then go to the sympathetic ganglia and form the cardiac plexus along with a branch of vagus nerves at both sides, and that is the deep cardiac plexus, which then supplies the heart. However, if we talk about the superficial cardiac plexus, it is formed by only the left superior branch of the cervical ganglion. This is the sympathetic part of it. And important and high yield is that it is formed from left vagus only. So only left vagus, not the both of the vagus nerves, contribute towards the superficial cardiac plexus, and it lies in the superior mediastinum just beneath the aortic arch. The deep is, however, located in front of the tracheal bifurcation. It involves the sympathetic from both sides as well as parasympathetic from both sides as well. So this was a little confusing initially, but if you do it this way, if you see that the nerve supply of pericardium is by phrenic nerve and the cardiac plexus and vagus, left vagus nerve, you'll be able to understand it. Again, also, I would like to point out a very important MCQ that along with phrenic nerve, which artery travels, that is the pericardiophrenic artery. Please note that the superficial plexus lies very close to the ligamentum arteriosum and the left recurrent laryngeal nerve. So whenever there is an aortic aneurysm, basically the aneurysm of the aortic arch, it will compress all of these structures, resulting in hoarseness of voice as well as cardiac reflex abnormalities. Now coming to the venous drainage of the heart. So the main venous channel of the heart is the coronary sinus, It is present in the coronary sulcus and it drains the blood from the heart and opens into the right atrium. So now the tributaries contributing to the coronary sinus, as you can see in this diagram, are the great cardiac vein. Then we have a middle cardiac vein. We have a small cardiac vein, a posterior vein of left ventricle, and oblique vein of left atrium. I will write these down for you. Now, a high yield point about the great cardiac vein is that it starts at the apex in the sulcus and it drains into the coronary sinus as we just discussed, and it accompanies the anterior descending artery or the left anterior descending artery. So the vein accompanying the left anterior descending artery is the great cardiac vein, as you can see labeled in the diagram as well. This is the LED, and the other one, the one in blue is the great cardiac vein. Regarding the middle cardiac vein, it is present in the posterior interventricular septum. So in the posterior IV septum, it will be drained via the middle cardiac vein and it accompanies the posterior interventricular artery. So the one accompanying LAD was great cardiac vein. The one accompanying the PIV will be middle cardiac vein. Now coming to another important vein, which is anterior cardiac vein. So anterior cardiac vein does not drain into coronary sinus. However, it drains the ventricle directly into the atrium. We are talking about the right ventricle. So it will be drained directly into the right atrium via anterior cardiac vein. Again, this is an important MCQ. All of these were important MCQs as well, and the coronary sinus being the main venous drainage of the heart. It actually drains the 2/3 portion of the blood of the heart. Now we're done with the structure, the nerve supply, the venous drainage. We have already done the arterial supply of the heart. We will talk about how the heart maintains the pressure or what are the reflexes associated with it. So let's start with the autoregulation of the circulation. So the circulation in lungs is basically maintained by hypoxia. We'll study this in detail in respiration. So hypoxia causes vasoconstriction. The circulation in the heart is associated with the local metabolites. So local metabolites which contribute in the heart circulation are nitric oxide, carbon dioxide, and oxygen. So hypoxia, adenosine, the carbon dioxide contributing towards the pH, and nitric oxide are responsible for the heart circulation. The brain is also maintained by the local metabolites, mainly carbon dioxide, which is pH. This is a very important MCQ. Kidney is autoregulated by myogenic and tubuloglomerular feedback. They will be discussed later on. The skeletal muscle circulation is autoregulated via local metabolites as well. And the local metabolites are, let's learn it with the mnemonic chalk. So CO2, hydrogen ion, that means the pH, the adenosine, lactate, and potassium ion. So all of these maintain the skeletal muscle workflow whenever it is working. At rest, the sympathetic tone maintains the blood flow. For skin, so for heart, it was local metabolites. For brain, it was local metabolites. For skeletal muscle, it was local metabolites. For skin, it is different. It is maintained by the sympathetic stimulation, and it is the most important mechanism for temperature control. So there is often an MCQ asking कि कौन किसकी sympathetic से maintain हो रही होती है, that's the skin. Local metabolites से जिसकी हो रही होती है वो है heart, brain and skeletal muscle. This is an important part of it. Okay, so let's see what happens when there is a lot of blood loss, when there is shock, or when there is hypotension. We would have often heard of reflex tachycardia, reflex bradycardia, what it actually is. So, जो हमारी body में blood pressure होता है या loss of blood होता है, it is maintained mainly by three ways, mainly through sympathetic adrenal response. The most immediate response is via the baroreceptors. जो most potent या most important or initial important response is via the CNS ischemic response. जब brain में blood नहीं जाएगा, it will generate a response and increase blood pressure. This is usually when the blood pressure falls below 60. It triggers the CNS ischemic response. The chronic and long-term maintenance is through adrenosympathetic system, which is the renin-angiotensin system. So sympathetoadrenal is the response in the shock as whole. Immediately baroreceptors आते हैं, and most potent one is the CNS ischemic response. If there is an acute blood loss, baroreceptor reflex will be generated. If there is a severe hemorrhage, the most immediate one will be baroreceptor, whereas the most potent one will be the CNS ischemic response. और जब BP बहुत ज़्यादा कम हो जाता है, CNS ischemic response again. अब what is baroreceptor reflex? So baroreceptor reflex is basically that there are receptors present in the carotid sinus and the aortic arch. They detect the stretch on the muscle, and due to that they determine if the blood pressure is high or low. If there is more stretch, so अगर blood pressure ज़्यादा है, that means the mean arterial, अगर blood pressure ज़्यादा है, that means जो mean arterial pressure है वो normal है, it will be normal. ज़्यादा होगा ज़्यादा stretch होगा, ज़्यादा होगा ज़्यादा stretch होगा, कम होगा कम stretch होगा. One important point, that baroreceptor is present in the adventitia of the artery, the large arteries, which is carotid sinus and aortic arch. A carotid sinus is present at the bifurcation of common carotid artery. It fires through the glossopharyngeal nerves. Whenever there is a rise in mean arterial pressure, it is detected by the carotid sinus. वो फिर उसके बाद उसको glossopharyngeal nerve के through fire करेगा towards the nucleus, and in the aortic arch it is via the vagus nerve. So both of these will send its signals to the solitary nucleus of medulla. So whenever there is a decrease in mean arterial pressure, there will be a less stretch on the vessels. Adventitia में जो baroreceptors है, they will detect it, especially the ones present in the carotid sinus and the aortic arch. यहीं पे baroreceptors होते हैं. So the carotid arch will send a stimulus through the glossopharyngeal nerve. Aortic arch will send a stimulus through the vagus nerve towards the solitary nucleus in the medulla, and this will in turn increase the mean arterial pressure. There will be a decreased firing. So due to decreased firing of baroreceptor, the blood pressure will increase. So that is why if we give blood pressure lowering drugs, for example, alpha blockers, it results in reflex tachycardia. So if a boy stands from lying position, the BP normalizes. That is an immediate response. It will be through baroreceptors. In orthostatic hypotension, the reflex tachycardia. Okay, so this one was important for the immediate control. For the long-term control, the renin-angiotensin system is responsible. If there is low blood flow to the kidney, aldosterone is released from the renin-angiotensin system in the shock state mainly, and we will do about it later on in detail as well. So this was all about the physiology. Just remember one more point, that if there is an MCQ mentioning Berry's aneurysm, which occurs in the brain, it in the anterior communicating artery, it will be due to a lack of tunica media layer of the artery. If there is a dissecting aneurysm, it will be due to tunica intima. If we're talking about arteries, I would also like to mention that arterioles are the one which have the maximum peripheral resistance. Veins have the maximum compliance, and capillaries have the maximum diffusion rate or the surface area. These are also important MCQs. So this was all for today's video. Please subscribe to my channel. So this will provide you a nice quick summary of what we did in all videos before as well, and conclude the chapter. Thank you.